10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Recording has started.
Hi, good morning everybody, and thank you for joining us on this webinar this morning. We're going to, over the next hour or hour and a half, discuss something that is going to be extremely important for all of us. And we really thought of accelerating this because it's something we need to use in everyday life. And these are the Society of Fetal Medicine India-oriented guidelines for ultrasound establishments during this COVID-19 pandemic. It's undoubtedly the worst calamity that mankind has ever seen, not only in numbers, but in terms of tragedy. And let's hope we can do our little bit to make sure that our patients stay safe and that we stay safe. And to help me with this webinar, I'd like to thank for being with us this morning, Dr. T.L.N. Praveen, the president of the Society of Fetal Medicine, Dr. Krishna Gopal, who is our executive secretary, and Dr. K. Aparna Sharma, who is joint secretary for 2020-2022. And thank you for being here this morning. I'd also like to take this chance to thank our trade partner in education, Lifestyle Diagnostics, for being kind enough to be a part of our educational programs. And this webinar has been contributed to by them so that each one of us carries home the right message. We are also...
Dr. Khurana?
Yes?
Could you stop sharing and start the PPT again, sir?
Yes.
Yeah. Please start sharing again, sir.
Is that comfortable enough?
I'll just take a moment to confirm to you.
Yes. Apologies for this interruption. We are doing this from 5 different locations. We have 4 of us, each of us sitting in our own home. And of course, I would like to take this chance to thank our communications technology partner, Blue Jeans, for making this possible. They also have a large platform which makes sure that all of us can see this and that nobody gets excluded. If you have trouble logging in or your friends are having trouble logging in, you could WhatsApp Mr. Vishal Mithal in the office on his phone number and he will send you the direct link. Are we okay to go? Do we have a communication from our web partner? Are we all right? Yes. So
yes, sir.
Nice. Yeah. And so we came up with these guidelines because of 2 bits of inspiration. The first was Dr. Gorika Sahi, who works with me in my clinical service, and she said that there's so much on the net in such a short time and we don't know what to look at. And she decided to undertake writing the first protocol for us. And the other inspiration came from Dr. Chandalula from Mumbai, who said, look, after the lockdown, there's going to be chaos. And we've got to know, what do we do first? What do we do last? And could the Society of Fetal Medicine do something about it? And we said, wonderful. So then we took some inputs while we were going along. And I'd like to thank Dr. Binu Batra from Kochi for that, and Dr. Chandrasekhar Sohoni from Mumbai for his legal inputs. And everybody on the list that you see on the left then got together to put this document. We had excellent inputs from larger hospitals, from Dr. Aparna Sharma, who is at the All India Institute of Medical Sciences, New Delhi, and from Dr. Sumitra Bachani, who is at the Safdarjung Hospital, New Delhi. Dr. Rima Bhatt is from the Army Hospital Research and Referral in New Delhi, and inspired me to look at the concept of triage, which ensures that the maximum number should get the maximum benefit without damage to the workforce and without losing lives. We also had Dr. Bimal Sani, Dr. Mohit Shah giving us inputs, particularly local inputs from Aurangabad and Mumbai, and help us along. And Dr. Sunil Mehta, who works in Jodhpur and has a practice which is a largely walk-in practice, where there is no system of appointments. People come because it is Tuesday and they got transport to arrive. And we've tried to incorporate part of that into our guidelines as well. and of course Dr. Krishna Gopal and Dr. T.L. Praveen, who are here with us, helped us in the finalizing of this document, and therefore we have this document. It was published and went online with the peer-reviewed journal, our own Journal of Fetal Medicine, last night. And I'd like to take this opportunity to thank Springer, our printing partner for the journal, publishing partner for the journal, who was able to push this at top speed so that it is now available as a peer-reviewed guideline specific for India and other developing countries with resource restriction and our own very peculiar patterns. And so we will take you through the peculiarities of an ultrasound examination that threaten healthcare professionals, the indications for performing ultrasound scans during the pandemic, how you could go about doing some patient scheduling so that the patients are safe, you are safe, and the type of report is not compromised, that our skills are called for, but we don't make errors. We will also talk in detail about the patient evaluation at the first point of patient contact, the triaging of patients, and appropriate personal protective equipment. We will talk about informed consent and also show you the informed consent form that we have evolved to make sure that everything is there. This informed consent also includes a declaration and also it's a disclaimer wherein we know that the patient should be aware that by being in a public place, he or she might actually get the disease, and therefore they absolve us of blame and that they've come here of their own free will to get this done. We will go into details about sanitation, both in terms of the venue and rearrangement of the venue, and equipment sanitation, which we will go in detail. The maximum number of questions we've got since we prepared this document about a week ago was on how to clean equipment, and we will discuss that in detail. We will also discuss how important it is to accelerate the availability of final reports, the advanced resourcing of protective devices and materials so that we don't run short of them, and we know that in a pandemic these are bound to be in short supply, and staff education. With that in hand, we will show you this list, which is the list of references that we have used, but let me not put you into snooze mode by telling you what we took from where, but to tell you in general that we have worked on the original ISWOG documents, the recommendations of the World Health Organization, importantly our recommendations by our very own Ministry of Health and Family Welfare, which has given us excellent guidelines on how to sanitize and how to clean. We have clinical inputs from the Royal College of the United Kingdom, from Spain, France, and Italy, which are bearing the brunt of this disease in Europe. We have inputs from China, Hong Kong, and Singapore, which have also had their huge share of the disease, and from the North American continent, particularly the Canadian guidelines, which tell us how to handle the situation. We also understand that the Centers for Disease Control in Atlanta have excellent inputs, and we have used those as well. And the story started from two documents from the International Society of Ultrasound Obstetrics and Gynecology, and you know that the Society of Fetal Medicine works with them as a sister concern. We have a safety statement from them, which came out about 10 days ago, and a consensus guideline. And this is what we have worked on extensively and adapted this to make sure that each one of us in our part of the world is able to go through this. The important thing about these two documents is that they clearly state that in guidance in relation to the personal protective equipment differs from country to country and region to region, and that local guidance should be followed when this is available. And this document of the SFM guidelines, which are India specific for ultrasound practitioners, is an attempt to fill that space because we have our own context. We have a heterogeneity, we have a varied education level, and we also have a very varied intelligence and stupidity level. We have to fight with the University of WhatsApp, and it is tragic that patients actually believe that that is true, but we try to overcome that. We, of course, have our varied economic status, and so we have to be kind to our patients and realize that this is not the time to boost our own personal economies. We have cultural beliefs and practices in India which have come to the fore by the media, and we want to make sure that this document separates myth from scientific fact. But we must emphasize that, like in the ISWAG document and all the other documents, a lot of this research is very recent because the pandemic is recent. So if your pandemic is recent, a lot of this is is evidence that is not so robust, but it's all that we have. And so we're putting it all together, exaggerating it where we think it should be exaggerated because of our particular lifestyles in our part of the world, and therefore we have prepared this document for you. Now, right in the beginning, of course, for those of you who have not had time to go through the basic sciences, we know, and this is important from our protection point of view, that we have respiratory droplets from coughing, sneezing, loud conversation, and direct contact. And these are responsible for the spread of the virus, which is the SARS-CoV-2 virus. So whenever body fluids originating from the respiratory tract of an infected patient touch another person's eyes, nose, or mouth, or an incision or a laceration or an abrasion, then the virus can enter the human body, and this disease that it causes is called COVID-19. And that is important to realize that, like all respiratory viruses, it actually may not manifest for a while, and therefore carriers may be asymptomatic. And this is a very important part of these guidelines, that this piece of basic science tells us that we have to look upon each patient as a potential person who can infect us. We also have to realize that we ourselves and our staff can infect any patient, and therefore precautions have to come from both sides, from us and our organization, and from the patient and their attendants and their relatives. And therefore it would be prudent to presume that every patient and attendant is a potential source of infection, and use that as a starting point to rationalize the kind of practice that we are going to be doing. Also, that the end of the lockdown does not mean that the disease has gone away. The end of the lockdown simply means that the graph has been contained to a point where statistics tell us that we can allow part of normal life to return with precautions. So these precautions will truly have to go on and on and on until there is an official end to this pandemic from the national and international agencies. And each one of us must therefore protect our patients and protect ourselves until the end of the pandemic. So this is not something that's going to end in April or May. This might go on for the better part of this year. Also, do remember that as soon as the lockdown is lifted, there's going to be chaos, because every patient will think that their condition is the most urgent. And that's understandable. After all, the patient does not understand what they're going through. And then we have to make sure that in spite of the pressures of volume, we will maintain all these precautions, especially distancing. We will use tact to handle them appropriately without getting angry with them. We will use our knowledge to continue to protect ourselves. But most importantly, do remember that the medical profession is likely to be forgotten again in our part of the world, and we do need security measures. And for this, we need to be sure that we're in touch with our local police, that we have our own security measures, and that we make sure that we're constantly aware of what's going on. Maybe one person on our staff can be responsible to see when a situation starts going out of hand, and make sure that we have a hotline to security measures, and an armed security force pretty much may be called for in several parts of our country. This massive patient overload can only be managed by being prepared. And being prepared is the only answer in this situation, if I may repeat myself. Moving on, do remember that this document is a guidance note and not a compulsory protocol. It would be wise if you look upon it as a compulsory protocol, because technically speaking, this is a minimum protocol. And you can modify it, but may I request you that when you modify this, please enhance it. Don't reduce it, because this by itself is a minimum, and we truly must understand that. Also remember that an institution or a clinic can opt to remain closed for services as long as the regional law does not enforce an act called the Essential Services Maintenance Act. Health services come under the Essential Services Maintenance Act, and we might compulsorily have to remain open, and therefore do be careful and check with the local authorities whether you can remain closed if you don't have the resources to remain open. But make sure that you have them in the picture, and preferably an answer on email or a written stamped letter as well. Now, moving on to the first part of the guidelines, and that is the threats to healthcare professionals during an ultrasound examination. And therefore, I want to learn from Dr. TL and Praveen what are these threats that are peculiar to us that we need to handle in this situation.
Thank you, Ashok, and good morning, everyone. I hope I'm audible. Yeah. Am I audible?
Yes.
Yeah, okay, right. So the most important thing which we all come across in our day-to-day practice is that we have limited resources, particularly when it's a standalone ultrasound clinics, where we have a restriction for space, we have restriction for certain standardizations, which have to be overcome, particularly in this situation. The reason is that Dr. Ashok has very clearly told us about the various aspects of contamination, how we need to be careful about it. Now, when we come to a standalone ultrasound examination centers, the most important thing is the examination rooms. Quite often we may have a small examination room, but then now for this we cannot expand the examination room, but at least we can make it more ventilated. In the sense, we can open up the windows, we can get the light come in, we can get the cross ventilation to be available. Not only that, in case if you are using air conditioners, the most important thing which we should realize is that air conditioners which have a HEPA, that is the high efficient particulate arrest filters, which are incorporated in it, are very, very essential, so that we can at least filter some of these things which are particulate material which are being thrown in. Not only that, if it is a window model where we have a vent that we can open up to the exterior, then it becomes much more useful rather than a single unit or a central unit which is going to give us the air conditioning. Now, another most important thing is, quite often when we are doing ultrasound examination, I'm sure most of us stand by the side of the patient and try to examine the patient, do an ultrasound scan for the patient. This, of course, we cannot avoid. Only thing is that we can extend our examination place by extending the cable size. That is, you can take the whole length of the cable. Quite often, we hang the cable so that it is much more comfortable to us to be close to the patient and do the examination. Now, I think probably we can get the machine away from the patient, at the same time have a lengthier the transducer cable, as you can see here. And once you have that one, you can little more distance yourself from the patient. This is how you are going to maintain the distancing, and which is what is very, very important as far as the transmission is concerned, because of the droplet infections. Now, at the same time, quite often in our practice, particularly when we are doing antenatal scans and all, there is always a possibility that there is some difficult situations where we have to extend our examination time. In this examination time, when it is going to be very long, it's always better to break the examination time. Ask the patient to wait for some more time, maybe about half an hour or 1 hour, and then again take them back. This does not mean that you are going to prevent yourself from the infection, but it is only a break in continuity that is going to be helpful. Not only that, if you think that it is very difficult to come to a conclusion, it's always better to ask the patient to go to a second opinion from one of your colleagues who is also working in your own place, which becomes much more easier, because he will be looking at the case in a much more fresh mind. Now, coming to transvaginal and transrectal, that is the endocavity examination, ultrasound examination, quite often it is very tricky. We know that whenever we do an endocavity applications, we try to take all the precautions that are required as far as the probe contamination is concerned. Well, it is very difficult to say that not to use an endocavity application in this situation, because quite often the emergencies which you are going to get, particularly in the form of ectopic pregnancy, yes, you have to do a transvaginal examination. In that situation, you may not be able to avoid them. But then invasive procedures, particularly the fetal sampling as well as fetal reductions, all those things can be avoided at least till the lockdown is lifted up. Now, whenever we have a patient who is coughing, sneezing, or sneezing, these are the patients which we definitely would like to have them. I mean, we insist that most of the patients should come into your examination room with the head cap, the cap, as well as their mask, and preferably wash their hands before they enter into the room, or sanitize their hands. And at the same time, avoid having loud conversations, and try to make the patient more comfortable, and let her not have an anxious deep breathing, and at the same time sighing by the patient, because which is quite often associated when they are really anxious about the thing. So you have to calm down them, and then try to talk to them. Now, repeat handling of the transducers. This, of course, most of us keep doing it. The reason is that we may start off examining a particular patient with a particular frequency transducer. We may have to change that one into a higher frequency or a lower frequency, or you may have to do a endocavity application. In all these situations, try to minimize as much as possible. If not, of course, you cannot avoid using them, because there are certain informations which can be gathered by using different transducers. Now, coming to the machine, the desktop, one thing is, we all know that there are certain high touch areas. These high touch areas in the machine are the most important things that we have to keep in mind. When you are handling the patient, it's always advisable that you need to use a disposable glove. And whenever you finish the examination, remove the glove and throw it off, so that that particular glove is not going to be. And then use a wipe in order to clean your machine desktops. At the same time, touch screen, I think it is better we avoid, because most of the times you can handle the examination by using the desktop. In case if you can avoid desktop and go and use the touch screens also, but then try to use one of them instead of using both of them. Now, trackball, whenever you want to measure or whenever you want to do certain calculations, yes, trackball is an essential thing. Now, the unfortunate or the tricky situation with the trackball is that it moves in and out. So you need to be very careful when you are cleaning or disinfecting these trackballs. You need to wipe, good wipe, which is a disinfectant wipe, and try to use it and rotate the bulb as much as possible, the ball as much as possible, so that you can do. Now, coming to the recording devices are with you, in the sense this is what you would like to record whenever you have an interesting case. These things can still go on. Only thing is your flash drives or hard disk which you are going to use to be again sanitized. At the same time, when we want to give the patient with the hard copies of certain images, again, that also the copier should be sanitized. So these are all the various precautions that we need to take as far as the threads from the head.
Answers all my questions so far, except one of the questions on what is the protocol for invasive fetal procedures, and we will discuss that during the question answer session. So moving on to our next section, which is the indications for performing ultrasound scans. I want Professor Aparna Sharma to tell me, how do we go about triaging these patients into the categories that will guide us further.
Yeah, hello everybody, and I would at the outset like to thank Dr. Khurana for and the entire team for taking this timely action. Now, I would like to say that, these are the times when we have to be extremely careful. First of all, before doing every scan, let's be very careful that whether it is required or not. And this is the time when we have to think about telemedicine, and every appointment has to be, if possible, triaged on the telephone, if possible. That's number one. Take the history on phone and screen it on the phone if possible. Number one. And we need to understand that if possible, and the guidelines, as we have mentioned in the guideline, it is TOCC. So take a detailed history of travel, occupation, cluster, and contact. Along with that, any history of symptoms. So if that is negative, so we have screened and then look at the indication, right? So we will be discussing that. Does this woman need to be scanned? Now, there are certain indications in which the scan needs to be done without delay. Now, in the first trimester, what are those indications in which the scan needs to be done? Like, this is not the routine dating scan. So in the first trimester, 6 to 10 weeks, she is routinely newly UPT positive. I don't need to do that scan. The routine dating scan can be done along with a NTNB scan at 11 to 14 weeks. So that is not a scan without delay. So a scan without delay is when the woman is heavily bleeding or you're suspecting a ruptured ectopic pregnancy. It is an obstetric emergency. In that situation, maybe you would need to do a scan without delay. Again, remember, if even at this time you have a patient who is probably a suspect, are you a center who's equipped to do a COVID scan or not? So please identify this for yourself even now at this point in time. So we need to be careful at all times whether you are a center who's designated to do a COVID positive or a suspect scan. So in that situation, you are eligible to do a scan without delay for an obstetric emergency patient. So this would be like an ectopic pregnancy or bleeding. Then there would be certain scans which can be done with a bit of delay. Like, for example, your NTNB scan can be done within a window period of, all we know, between 11 to 13 weeks and 6 days. So currently she is 11 weeks. So maybe she can delay it up to 13 weeks and 6 days, by which time we hope that the lockdown will be released, and by that time you can possibly postpone it. Even a level 2 scan can be delayed for a few weeks. Definitely the growth scan can be delayed for a few weeks. What cannot be delayed is probably if the patient is severe IUGR with a reversed end diastolic flow or an absent end diastolic flow. So please do consider that whether you are equipped to do a scan with proper precautions, as has been quite nicely told by Sir, that if you are equipped to do a good scan with all probable precautions, these are the scans that you need to do: an absent end diastolic flow, a reversed end diastolic flow. So such scans need to be done, right? But not routine reassurance scans or a routine growth scan. That should not be done. Again, there should be scans which can be completely avoided or postponed. Ultrasound for reassurance, ultrasound for confirmation of pregnancy. Otherwise, no other obstetric indications should be completely avoided. Sir, can I answer those questions about fetal medicine procedures?
Yes, of course. Yes.
Right. So for the fetal medicine procedures, as I said, first of all, every procedure, if it is indicated or not, you should completely see the indications which you are routinely doing. So if you have confirmed your indications, the necessary precautions again is that you should screen your woman for history and symptoms. If the history is there for travel, occupation, cluster, contact, then in that case, again, send the patient to the screening area, and whether the patient needs to be tested. If the patient is asymptomatic and she does not have a history, then it's all right. If the patient is symptomatic, again, see whether the patient needs to be tested. If there is no symptom if there is no history, then in that situation, you take up the patient for the procedure. Now, your fetal medicine center, then there is no other extra precaution apart from taking your basic precautions that the universal safety precautions that you take for. If, however, you have any other doubt, that we will be discussing in the usage of PPE, that I will come to it later in the subsequent part. But the most important part is universal screening by history and symptom for every woman that walks into your fetal medicine or ultrasound clinic for COVID symptoms and history.
Thank you so much for introducing this to us, because this is truly the most frequently asked question after sanitation. And what I would really like to go over with the next 2 slides is in detail of what we have just given you an idea of. The first is the indications that need to be considered in another perspective, because I know that's how it works out the best. And then, of course, we will come back to our TOCC, history, etc., triaging a little while later in the webinar. So, Dr. Aparna, could you summarize everything that you've just told us once again, so that people have it back to their minds, that yes, these are the ones we can do. Plus, it gives them time, of course, to take images from this. We now, of course, have these available free of cost from our journal website, which you can find since last night. And because these are guidelines, nobody has to pay for them, whether you're a member of our society or not. So if you could please summarize this slide for me, and of course, give details wherever you think necessary.
Yes. So to start with, the dating scans between 6 to 10 weeks should be postponed, and the dating should be done at early morphology 11 to 13 week scan, as I discussed previously. Because as soon as the pregnancy is positive, this is an extra visit which actually exposes the lady as well as healthcare providers to an additional risk of infection, which is absolutely not required. But the patients with history of bleeding per vagina or pain need an appointment prioritization. Bleeding score can be assessed based on pictorial graphs which are available. Again, if the bleeding per vagina is not very severe, the patient can wait, and it can all be done based on the telephonic facility if it is available. Again, the anomaly scan at 18 to 20 weeks may be delayed by a few weeks. And even under these circumstances, it is likely that the patient will be able to obtain permission from a district court along with a medical board opinion for delayed termination in case of a major or a lethal anomaly. And now with change coming in, I think it is going to be much easier for us. Second trimester scans should be given priority over first trimester scan. And yes, if in a situation a patient has missed out on the 11 to 14 week scan, the 18 to 20 week scan can be a very good alternative in these kind of a scenario. So I think we should insist more on the second trimester scan to give a priority over the first trimester scan, and we should be with the patients in these times, and give them counseling that okay, if you have by chance missed over the 11 to 14 week scans, you still have the second trimester scan. And similarly, if the first trimester screening has been missed out, you still have the quad. So let's not miss out on the quad screening if we have missed out on the dual marker. So these are the things that as fetal medicine experts, we should be telling our patients that you still have the quad marker, which has a good detection rate if you have missed out on the dual marker. So I think these are very important points that we should be telling our patients.
Yes, and as you know, the expert committee that has put these guidelines together has put each one of these sentences that you're seeing on this PowerPoint as written black and white documentation in the guidelines, so you can refer to them again and again. If you have a doubt, keep these on your smartphone, file them in a situation amongst your files where you have easy access, and just read them whenever you want. We have a title for each one of these, which is the same as the title you're seeing on this PowerPoint presentation. And so there will be no element of doubt that you can do it. And also you realize that there is not much variation in the interpretation. It's not subjective at all. It's so straightforward that decision making is definitely going to be a lot simpler. Moving on to our next aspect, and that is for the recommendations for scheduling, patient scheduling, and for doing the various scans based on the indications. I'd now like to ask Dr. Krishna Gopal on how do we go about handling this? The routine growth scan, no, before that, can we also have Dr. Aparna's opinion on this particular slide? On routine growth and Doppler scans versus decision-making growth and Doppler versus FIGO regulations, and what will we do?
Yeah, so again, as we discussed, that the routine growth and Doppler scans should be postponed. So normally between the 32-34 scan that we normally recommend is that we can be postponing it to 36 weeks assessment. And if the pandemic recedes, this can be rescheduled earlier. But the decision-making growth and Doppler scans between 28 to 41 weeks should be considered on a priority basis. Like as we discussed, if there is decision-making scan, like there is an AEDF or an REDF, then in that case, we should be doing that scan depending on our ability of that center to perform that scan with safety. Information from this scan dictates the time, place, and mode of delivery. And this decision may be critical to save the lives of mother and fetus. So this particular scan should be individualized based on the patient and the ability of the center and the ultrasonographer to perform that scan. The 36 weeks growth and Doppler scan is a useful triaging tool for early delivery decisions and may need to be carried out, although the FIGO recommends clinical assessment and delivery during a pandemic. So this particular is a decision, is a recommendation that it should be taken by the clinician and the ultrasonographer in tandem, so that you can do a justice to it. The above mentioned prioritization will need to be modified depending on the extension of the lockdown. So this 28 to 41 weeks scan will need to be done depending on the condition that we are looking at. If it's a critical condition of FGR with a serious situation of AEDF and REDF, we need to look at it with a serious situation and do it if it is required. But the routine 34 to 36 weeks growth scan can be postponed. So that's the take-home message for the growth and Doppler scan.
So if I have, for instance, growth restrictions that I'm following up, I should keep on following them up. If I have a diabetic patient who's poorly controlled, difficult to control, then I would like to follow them up. Or if I have a patient, for instance, who needs a follow-up because she has a heart block that needs monitoring, then it would be justified for the patient and me to keep following them up. Would you agree on all of these varieties of indications to give specific examples? Yes?
Yes.
Yeah. So moving on to our next point, and this is again on patient scheduling. And Dr. Krishna Gopal, can you tell us how we can intelligently schedule these patients to make sure that they get the best, that we are safe, our staff is safe, and the most important thing, our patients remain safe and yet get the best advantage of ultrasound, which today really has become such an integral part of clinical decision making. So I think, Dr. Krishna, you'll have to unmute your screen. Yes.
Good morning, all.
Yes.
Good morning, all.
Good morning. Good morning.
And happy Easters to in this pandemic-like situation. This aspect is extremely critical for the safety of not only patients but the doctors as well as the clinical staff. As Dr. Parveen sir has pointed out, that infections can be from patient to the doctor and staff, and from doctor and staff to the patients as well. So idea is the people distancing. So we have to start our scheduling not only at the center level, rather than we should sensitize our referral doctors as well, that each patient must call to the center to schedule their appointment before coming there. Even if due to the several calls at the same time our staff could not take one call, then they can again call and they should take the proper appointment and scheduling before coming there. We should even schedule the urgent patients as well, and in most of the India we have the telecommunication very well established. So we can schedule it quite simply, just we should avoid doing all the walk-ins at this stage of the time. It is also important that we should keep one experienced staff on the phone, and even we can give two phone numbers at the same time, and they should coordinate with the patients. Sometimes one of the scan take longer time than what it is expected. So that is why I always suggest that even if we give a certain time to the patient, like the 12:30, then again patient has to call us before visiting the clinic, and the gap between the appointments should be based upon how many staffs we are having, how much our waiting spaces are, how many the scanning rooms are, and the most importantly, what kind of scan it is. Like if I am doing a 18 to 20 weeks scan of a twins, it will take much larger time, but much longer time. At the same time, we have to ensure that what is the turn around time, like when the patient walks in and walks out. So at any situation, we have to ensure that patient should call us before visiting to our clinic rather than coming walk-in.
Thank you so much. That will really help us a lot to get organized. Now, moving on and back to Dr. Aparna Sharma, this is the concept of the total history details that we were talking about. Can you tell us, Dr. Aparna, how do we go about this in an even more detailed way? And repeat some of the points that we've already said. We are unable to hear you. Have you unmuted yourself?
Yes, sorry, I had muted myself. So why is it important in the first place is also from our practical experience on what is actually happening is that, as healthcare providers, we are not very, very careful. I must say that because, we reflexly kind of do things and we are not really, really careful when we do it. So we have to make it a habit because we are used to have walk-ins. So when we have patients, ideally, we should be carrying this history taking and scheduling of appointment on phone. However, if that is not possible, so as soon as a patient arrives in the clinic, immediately we should have an objective form which is there. A screening form should be available in which a proper history is there of, as I mentioned, the travel, occupation, and cluster and contact. And a detailed history taking is once it is done. Ideally, a recording of temperature of the patient and the attendant is ideal. If it is not possible, it could be cumbersome and impractical. If possible, it is good. But then patient might be taking paracetamol before coming in, and then, patients might not be giving a history. So as far as possible, everybody should be considered, somewhere to have some kind of a history. So be careful. So we should be taking all possible precaution. Another very important thing that I will also say is that we have to understand that what is PPE. Personal protective equipment does not always mean a hazmat suit. It's not always a full-on suit. So personal protective equipment is of different levels, and not everybody requires a hazmat suit. So here, as been shown on the slide, a history of travel, occupation, contact, and cluster is recommended, and who should take a history and experienced staff should be deputed to handle. Otherwise, it just remains a checklist. A travel should include a detailed itinerary, transit locations, and date of return. Occupation should be asked as a direct question on what you do. A history of exposure to a test positive case should be asked directly for. And a history of living in a known positive cluster or visiting such a cluster should be noted. And now what we have actually done is when we take the address of the patient, we also have a list of hotspots which has been declared in the city of Delhi, at least for our practical thing. So we have the list of things. So we exactly know which area that lady lives in, so that we have that she doesn't belong to a hotspot cluster or a nearby area. So it will be a useful thing to have for our own safety. A properly filled, signed and witnessed declaration and a written informed consent document should be obtained from the patient. A sample form is included in these guidelines. So please download it for your own safety, and you could modify it for your own region and include the areas which you think are hotspots in your own region, so that you can modify it for your own safety. Now, according to this, first of all, decide what is the center that you are working in. Is it your own setup of ultrasound where you're practicing as a person, you have your own setup and you're working singularly, or you're working in a setup in a hospital where you are actually catering to a COVID suspect or a positive patient also. So depending on that, you need to follow certain guidelines. Now, if you are
we'll come to those soon after the consent form, because there have been so many requests and the questions are pouring in. Sir, where is the consent form? So if I may put the consent form first and get Dr. TL and Praveen to give us details of that, and then we'll come back to the next set of triaging that we need to do. Yeah, sorry to interrupt you.
Yeah, no sir, no problem.
So this is the consent form. Dr. TL and Praveen, it doesn't matter how long you take over this form, just make sure that you repeat each one of these things, because I'm asked this question 150 times an hour.
Yeah. This is one of the most innovative consent forms that has been published, and I'm very proud that it is from our Society of Fetal Medicine, where there are certain basic criteria that have attended to, and there are certain issues which are very focused to this particular disaster situation in which we are in. Now, anyway, all of us will definitely take the patient's name as well as the partner's name. But at the same time, it is essential that we need to identify the attender also. The reason is that when you want to go back and check about these people, it's essential that you need to know about the attender's name and possibly their contact history also, in the sense contact possibility of able to contact them again. Not only that, by knowing the partner's name as well as the attender's name, we are going to identify a situation where they are coming from and which are the areas where it is hot spots that have been identified, so that we are much more careful. We know how to handle it. At this juncture, I would definitely tell you that I would prefer to have only one attender rather than many attenders, because that way you are reducing the numbers, that way you are reducing the amount of contact. And so it is always essential to insist that a patient with a single attender is always advisable rather than have multiple attenders. That is one. The second thing is the current address. Current address is one of the most important things, because as we all know, there are certain areas which have been identified as hotspots. Not only that, there are certain areas from where most of the COVID positive patients are coming from. So in that situation, knowing the current address is also going to be of great help to us. Current address and most often the permanent address, because in this situation, sometimes the current address may not be the permanent address, because they might have shifted to some other new place where they are staying in this situation, or they might have gone to a friend's place before the lockdown, and then once the lockdown is there, they are stuck there. So you need to know that permanent address or where they are staying right now. The second important thing is the history of travel. We know this has a great implication. As you have seen, people who have attended to this Delhi conclave, where it has been responsible for most of the transmission, which was identified because some of them were from Telangana area, where we could identify these people. So the history of travel to not only outside the country but also inside the country, right from where they are coming from and which is the place which is actually possibly involved in this COVID transmission. That is two. The next is date of departure from home. So we need to understand, as I said, there are certain situations where the lady might be staying in Delhi, but she might have come to her mother's place in Hyderabad. So it is essential that we need to know when did she travel and by what means did she travel. That is very, very important, because the travel history is one of the most important things because we know when she has started, whether at that time the COVID was really there, or was it just the initial phases, and by what transport she came, either by the train or by a flight or whatever it is, has to be identified. Now, we need to know what was the date of return. That this date of return is sometimes may not be really useful, in the sense, if she has come back again to Delhi and then she wants to get a scan done, that is the time when we need to know about the date of return also. Now, coming to the situation where we have the countries outside India, where the countries where we know most of the situations where they are really involved, and we are very in a great dire situations. These are the countries which we know. But then, as of now, I think this problem has partly solved, because now there is no international travel allowed. So, but then we need to know when the person has traveled from outside the country, and that also will give us information regarding whether they are. And then now, after about 3 weeks of lockdown, most of them are being screened. Most of them have been examined or investigated for COVID being positive. So this way one thing which we can be little assured of is the places and countries from where they have come back. Now, places of transit. See, suppose someone is staying in Italy, might have come through London, or someone in London might have come through Italy. So this is again an important factor which we have to know. Not only that, even in India, if suppose there is someone who is going to Chandigarh from Hyderabad, he takes a flight to Delhi, from there to Chandigarh. Again, this is an important piece of information which will help us in identifying these patients and sorting them out. Now, pilgrimages, sporting events, as well as the public events attended. This is very important, as we have recently seen that because of that conglomeration in Delhi, which has caused a lot of problems, and so identifying them and trying to understand the situation there, and trying to know the implications that have occurred because of their attending a pilgrimage place or a sporting event or a public event, can also give us some information in managing these patients. Now, occupation, particularly if they are occupied in a situation, let us say, for example, a dentist. A dentist is definitely a high source, in the sense they are highly susceptible because their profession is like that. There are certain professions where they are more susceptible. That is the reason why it is essential that we need to know the occupation of the patient as well as the occupation of their attendant. Now, coming to that's what I said, that the partner's occupation also is extremely essential, because if the patient may not be a carrier, but then the partner can be a carrier. That's the reason why it is essential to know about the patient's partner's occupation also. Now, history of contact with a corona positive, that is COVID-19 case. Yes, this history, but I am really little skeptical about this, because quite often patients may not reveal this. And then it is essential that we need to be intelligent enough to extract this particular information, because it will definitely help us in taking certain precautions when we are dealing with these patients. Now, fever, yes, no, and tiredness, yes, no, cough, yes, no, headache, yes, no. So these are all the breathing difficulty. These are all the features which we are expecting to be seen in a COVID positive. So in these situations, it is essential that we need to take. But well, there are, as Dr. Aparna has said, that if they have taken a paracetamol, has walked in and say that there is no fever, there is nothing that we can do about it. So because there is some amount of honesty that we expect from the patient and the patient attenders as far as the features are concerned, because headache you can't detect, tiredness unless the patient tells you can't. Of course, the cough, if she is coughing or he is coughing, it is difficult. You can easily make out. Now, coming to the other part of this particular consent is the patient's declaration. The patient's declaration is very, very important, because there are two things that it is very important for us. One is that the patient should not be affected by coming to your clinic. So that is one of the most important things, because tomorrow after the lockdown, if the patient says that I have got infected because coming to your clinic, it is very, very essential that at the time when she came to the clinic, she was absolutely free from COVID. That is one. Second important thing is that she has not contaminated from the clinic, because one thing is you can take all the precautions, but then in the waiting room or the waiting lounge, if there is someone who is asymptomatic and a carrier, it is very difficult to identify. So that's the reason why we need a patient's declaration, and at the same time we need to make them understand the medical implications of this particular procedure, that is the scanning, which we are going to undertake, the benefits and the pitfalls in it. So this is how we have today. Not only that, we need to have get a declaration from the patient that we are not responsible. This is one of the most important legal aspects that we have to keep in mind. It is not just doing service, but at the same time saving your own skin. It is essential that you need to take all these precautions before we take the patient, once they have been triaged by taking various aspects into consideration. I think I'm a little clear about what are the aspects that we need to cover as far as the consent and consent form is concerned. Thank you.
Thank you very much. And this again is a downloadable form, and you can use it exactly as you please. You may modify and add, but I would suggest we don't subtract from this form. Like I said before, these are anyway minimum guidelines, and truly should be followed very, very carefully. And that brings us back that once this form is done, and the patient is aware that yes, this is a responsible act, that she has to be sensible about it, that there is a risk, but it is an acceptable risk like anything in life, and that she absolves us of any legal responsibility because she's come off her will and because she needs this scan. We then witness that document by someone from our own organization, and then we say, okay, put the date down and have that signed. And Dr. Aparna, we now come back to where we were triaging patients, and the second step of the triage, which we take on after we've asked the symptoms and the travel, occupation, and so on. So could you please go through this all over again for us and tell us about this categorization on who should be scanned where?
So as I was mentioning, so first as we take again, as Dr. Praveen has so nicely elaborated on how detailed a history we should be taking when we are taking a consent on travel, occupation, contact and cluster. And we are very sure that the patient is negative as regards the history and as well as that she's asymptomatic. And we are very sure that she is very, very asymptomatic. Then we should be doing the scan with appropriate PPE. And when I talk about PPE, then I mean that it is PPEs of different levels. So when we actually go through the guidelines, we have given the WHO PPE, the reference to the WHO document on personal protective equipment. Personal protective equipment in all cases does not mean a full body suit. When a healthcare provider comes in direct contact or is caring for an actual COVID positive patient, in that situation, that healthcare provider is mandated to wear a full personal protective equipment, which actually means a headgear, which includes a goggles and an eye shield also, along with a gown, which is a non-penetrating gown, and gloves, heavy-duty gloves also. And so this is a full PPE for a patient who's, for a healthcare provider who's actually in the area which is aerosol generating. However, in the other situations like a screening area or a triage area, or so in that situation, we do not actually need a full PPE. So in the category A, which is asymptomatic here on the screen, asymptomatic TOCC negative, and there is no widespread community transmission as of. So in that situation, we might be wearing a mask, right? So a mask, and take all possible precautions to keep social distancing and use the precautions, but not be wearing full goggles or a shield. So that is the situation. If, however, you suspect a category B or C and you are not a designated COVID positive center, then you refer the patient to a COVID positive center and do the scan with a full PPE as we have mentioned in the guideline, and we have made a table separately. And so do the ultrasound with your proper protection, including a face shield and goggles. So take protection where required, because rational use of personal protective equipment is also very important. But take care of yourself, but in the proper conditions. So decide where you're working. Do you actually require to do the scan? If you require to do the scan, are you equipped enough to do the scan? If not, refer the patient to the designated COVID-19 center. So I think this is the message that is very, very important as ultrasonographers that we need to understand.
So basically, the bulk of us will be following into the category A, which we will examine after a careful evaluation like we've already outlined. And the B and C, we really should not take chances and refer to a designated center. And we can explain to the patient that, look, we're very sorry, but this is what the government has put into effect. This is what the WHO has put into effect. And this is what countries that have successfully fought against the virus, such as China, have put into effect, and that's how they succeeded. So this brings us again to repeat something for us, Dr. Aparna, and that is the fact that the categorization and the PPE. If you could go through this again. I also want you to tell me the difference between goggles and face shields as opposed to standard reading glasses, the difference between surgical and medical masks, and can you also tell me about hair cover? Dr. TLM Praveen did touch upon this. Of course, in an ideal situation, you wash your hands, you never touch your face, and technically that should be all right. But we do need to cover ourselves. So could you go through this little chart of the TOCCA category on one side first and tell us what each one of these mean, and then the type of masks and work clothes and what each one of these mean?
Yes. So I think, so for people who have, the people who have worked in any kind of a surgical area or even during the internship, if we have changed. So first of all, we should change away from our home clothes into work clothes. We should immediately, in these times, whenever you enter into your area for doing ultrasonography, change into your work clothes. Do not work in your home clothes. So TOCC is travel, occupation, contact, and cluster. So first of all, so if there is any history like that, so that makes you category B and C. So change into your work clothes, whether it is A or B. Because once you change back into your home clothes, then you're, first of all, you're safe in some aspects. Face mask. So for all practical purposes, surgical and medical masks are being interchangeably used in the present time. So there's not much of a difference between those two. N95 is the next level, and FFP2 and 3 they are kind of respirators, and they are not presently available in our country as of now. So N95 is what is available, and we are using it. It is the next level of masks which are available over and above the surgical masks, which are easily available for all kind of surgeries or any hospitals which are there. So if possible, so for your routine scans, any surgical medical mask you can use. But if there is any doubt or in a patient is positive, then in that situation you use an N95 mask. Hand hygiene is of course very important before and after any case. Eye protection. Yes, goggles is what covers only your eyes, right? And a face shield is what, if anybody has operated an HIV or an HCV case or maybe seen it being done, it is there, which is there over your head, and it comes right over to your face. So that's your face shield. So when we are actually handling a positive case, we use a face shield so that it covers your entire face. So it actually comes over your goggles. So it's very, very inconvenient per se, but it has to be used over your goggles. But it is over and above. So there are two types of the PPE which comes. So one comes with a goggles, one comes with a face shield. So ideal one is a face shield. So sometimes it is available, sometimes it is not available. But goggles is good enough if it is there. Hair cover, again, you need to put your entire hair, and then you put those hair caps so that your hair doesn't get exposed like that. And an isolation gown is a full gown which is there. It doesn't have to be like, zipped up like a hazmat suit, which is very fashionably out there, which is being worn even by the Hollywood people, and kind of not even available now for purchase. But yes, you don't really need to zip up in a suit, but even a full isolation gown is enough. So those suits are there for people who are in aerosolizing procedures. But for the other things, or even a low-level procedures, you can have a gown which is tied at the back. So even that is enough. Staffing is very important, that you keep one person at a time. You don't want an assistant at this time to assist you for a scan. Just have one person. And disinfection, I think, will be discussed in detail, sir. I don't think I'll go over to disinfection right now.
We'll do that. Somebody was mentioning.
How about the shoe covers? Is it essential?
Sir, as far as shoe covers, sir, when we are going into the COVID areas, what we are doing is that we are removing our home shoes and we are using the shoes which are specifically designated for the COVID areas only. And we keep those shoes, and when we are coming out of it, we are disinfecting that with normal sterilium. So keep your home shoes out if you are actually going into the COVID area. But if you are not in the COVID area, in your normal thing, so you keep a designated shoe cover for that area, like you are using your work clothes. Keep your work shoes. Keep those shoes there. Just disinfect them with sterilium and keep it there. Go home. That's it.
Correct.
And obviously, we all have our own opinions on this. Dr. Praveen still feels that we do need hair cover for our routine clinics. Do we need hair cover? They're not in the recommendations, isn't that so? Hair cover for our routine ultrasound work.
So as you said, it is a basic minimum. Add on to this, do not subtract. I completely agree with your statement, sir. Yeah. As you said. So these are some basic minimum requirements. Please add on to it, do not subtract. So we cannot make recommendations which are high because people would go higher. So I think what we make here are some basic recommendations from WHO which are to be done at all countrywide levels. So you can only go higher.
That's
right. Thank you for clarifying
Practicability. Practicability is very important.
Also, this remark about the patients who have been identified to be at risk for infection, the delay in their ultrasound scan, and then they come back to a center which is still my TOCCA center. How should that policy be followed?
Sir, as I said, sir, for any COVID positive patient, we cannot delay the care, whether it is obstetric care, whether it is ultrasound, for anything. And we are not doing it. We are actually caring for COVID positive patients. We just need to refer them. So like there are questions, whether we can do scan for twins, whether we can do scan for ectopics, we are actually doing scan for fetal anemia, for everything. But we just need to find that COVID positive designated center. We cannot, respectful maternity care, we cannot avoid doing scans. We need to refer them to the proper center.
Yes. So we're repeating this again and again, and I'm so glad we're emphasizing and we're all on the same page in this respect. Now we come to a very important area, and that is how do we rearrange our venue and sanitation of the area. And for this, I'm going to take some important inputs from Dr. Krishna. Dr. Krishna Gopal, could you introduce this and tell us about venue sanitation and rearrangement?
Yes, sir. Actually, we will start with a physical barrier. So physical barrier can be a glass windows, glass panels.
Sorry, I'm interrupting.
Plastic windows.
Sorry, the slides are not changing. It is static.
No.
The PowerPoint is not changing.
Sorry, the PowerPoint is not changed? We will double check that with our center. It has changed. TLN, maybe your internet has been down for a few seconds. Maybe you can refresh your screen. Okay. The rest of us are seeing the right screen, the correct screen. Yeah, it has changed. Yeah, yes, Krishna, go ahead.
Okay. Sorry. So, we will start with our windows. That is either with the glass or plastic windows. These windows are very helpful. Actually, there are several guidelines, but Society of Fetal Medicine has adopted WHO and the Ministry of Health and Family Welfare Government of India a guideline which is best suited for our country and subcontinent. So we have to do the triage at the triage area, in the registration, the desk at the clinic, and the emergency department by using the plastic and the glass windows, and that reduce the exposure of COVID-19 virus. Then the most important thing are the guards. guards are not that much literate, so we have to train them. We have to train them in the way that they should use the surgical mask, they should maintain hand hygiene, and they should communicate with at a distance of at least 1 meter. There are questions here from the audience as well that I will answer in between. That is one of the question was that should we allow attendants inside the waiting lounge? So generally it should be avoided. But if your waiting lounge is too huge and the patient load is too low, then you can maintain the people distancing by either strapping the alternate seat or two seats by the tape or something else. The idea is actually people distancing. Sometimes we have very small areas and we cannot allow all the attendants and the patients to come inside. So in that circumstances, it's better to ask to wait in the vehicle rather than in the waiting room. One question was there is a minimum and maximum time exposure during the scanning. So we should follow the principle of ALARA, that is as low as possible. So we should maintain the time as short as possible prudently, and there are few scans that may stretch longer. So in that circumstances, we have to break it in between for the shorter period, so that we should not expose the patient for the longer time. Few of the questions are about the air conditioning. So ultrasound environment is definitely different. There are smaller room, so we have to maintain the air conditioning unit to run in an open to outside air mode. That is the vent open. Clinics will have to decide individually how to best to facilitate maximum air change in the so the aerosol generating procedures there in the ultrasound clinic, and we should generally avoid it for the smaller clinic, and we can use it for the huge centers or the larger centers, but for the smaller clinic we should avoid AGPs.
Yeah. I've logged in. I have no problem. Yeah.
That's right. And also, what about waiting in the car? Dr. Krishna, what do you think about waiting in the car as an option?
Waiting in the car is always a good option. Listening the music in the car, in the air conditioning, you can have better environment there than in the waiting lounge. I believe so.
Yeah. And then we move on to other aspects of cleaning. And I'm going to go through these slowly because sanitation there are lots of questions related to sanitation, and I do hope we can cover these without going back to them during our question session. One is that we must realize that the clinic is not just the ultrasound examination room, and that we have an arrival gate, we have a pathway or a driveway, we have entrance staircases, we have lobbies, corridors, staircases within the building, escalators and elevators. We have waiting booths, we have question booths, we have office rooms, meeting rooms, and within a clinic we have pantries and cafeterias as well in some of them. And all of these can be cleaned with a sodium hypochlorite solution 1%, and we will discuss this later. And alternatively, you can use phenolic disinfectants, and we will discuss these and show you what we have in India, what we can use for equipment, and what we can use for the rooms, and so on. Now, the frequency of mopping the whole clinic in every single area would depend on how busy is the clinic. So typically for 2 to 3 patients an hour in a busy practice for more than one person, I mean, most of us doing obstetric scans know it takes us between 30 and 45 minutes. And therefore, we will put our patients about an hour apart, because it does take 10 to 15 minutes to wash hands, to sanitize, to get a report ready. And we have one examining room. But otherwise, if we have 2 to 3 patients an hour, you have 2-hourly mopping is recommended, and you must have this early morning major mopping, and after the last patient has gone, we will do another mopping after that. Now, also, the thing is that the question of starting the mopping, it should be from cleaner areas and proceed to dirtier areas. So because my ultrasound suite where I examine my patient is relatively unused compared to the number of people who cross it, and because it is often on an open vent air conditioning, I presume that that would be the cleanest place to start. And I would then start around the machine and then move on to near the door and then move on to the dirtier areas. And it's very important to understand that the cleaning staff must wear surgical masks and they must wear heavy duty gloves. There are 3 types of gloves available. We have standard latex gloves, which of course are all non-powdered these days. We also have polyurethane gloves, which are paper gloves, so-called transparent paper gloves. And then we have the heavy-duty glove. The heavy-duty gloves are thicker latex or thicker synthetic stuff because they don't wear and tear so easily and they don't get punctured so easily. So the cleaning staff should wear those. Latex gloves actually get damaged much more easily than polyurethane gloves. Our standard, cheap, inexpensive glove, the papery sound, the plasticky sound, that cellophane type of thing, is what we need, and that's the one we should use and throw away and use and throw away, because A, it gets less lacerated, and B, it's economical and equally safe. So we should try and use polyurethane gloves instead of latex gloves. And we've discussed goggles already, but appropriate hand hygiene remains the most important. That means you wash your hands in the old-fashioned style, 20 seconds of rubbing with standard soap and water, and everybody should be doing that again and again. It's very tempting for 20 seconds to sanitize your hand under a Sterilium or one of the other brands that are available. But the fact remains that hand hygiene remains the most effective. You are rubbing. And in the weather, as it's getting warmer and warmer, the alcohol is evaporating earlier. We may not finish those 20 seconds. And therefore, I really think that hand washing is fantastic. And make sure that you handle the doors of the hand washing area appropriately. You don't come out and touch the handle again. You should be able to push the door and so on, or somebody should open it for you. Now, all the high contact surfaces, such as the lift buttons, the handrails, the handles, the call buttons, the escalator handrails in the larger buildings, public counters such as the clinic counter, the intercom systems lying on the main registration desk, the telephones, the printers and scanners in the report preparation area, and other office machines should be cleaned twice daily by mopping with a linen or an absorbable cloth, not your ordinary kitchen duster, because that has fabric that accumulates virus. Use a linen fabric absorbable cloth soaked in a 1% hypochlorite solution, and how you prepare a hypochlorite solution is already there in the guidelines. We've given what bleach you can use, what powder you can use, what's commercially available, and how to mix it with how much water. It's given an extra one in the guidelines. Now, there are certain surfaces that can be done with alcohol, and it should be at least 70%, well, at least 60%, preferably 70%. And these are frequently touched areas like tabletops, like chairs, like the handles of chairs, pens. I just clean my pen all the time, before, after, during a patient. Office files, office registers. You know, some of us have to maintain manual registers under PCP and DT and so on. Some of us are lucky, we are electronic. Keyboards, mouse pad, tea and coffee dispensing machines, etc. Anything that comes to your mind and is lying there needs to be sanitized. And then you can use a 1% sodium hypochlorite, which you can prepare for the whole day and put into small little containers. And if you're using a sanitizer, make sure it contains 60 to 70% alcohol. Do remember that when you're cleaning metallic surfaces, these cannot be cleaned with sodium hypochlorite. So our metallic door handles, our security locks, our keys, you can't use those, the sodium hypochlorite, and you do need to then use our 70% alcohol sanitizer, and you wipe down these surfaces. It's easy sometimes to actually spray, and you use the spray and it's much more easy. but that's not correct. And the reason it's not correct is because the spray can spread the virus. You can use the spray to put onto the wipe. That is fine, because then it's not spreading around. But you put the spray onto the wipe and then use the wipe, that's fine. But otherwise, use the liquid so that it falls out as a few drops, and then you use that. Now, it's equally important to realize that the cleaning equipment, the dusters or the mops, must be rinsed in running water or hot water after use and left to dry. So for how many hours would I be using it? Well, each time I use a mop, I need to put it under running water and then I leave it to dry. When I use a wipe throughout the clinic and the cleaning staff is doing it, they finish one round, they wash it and they put it to dry. At all times, they're wearing their gloves. And that is how we are actually managing that. We also are recommending that we should have hand sanitizing stations, which should be installed near the entry and near high contact surfaces such as clinic registration counters, and the sanitizer is exactly the same. When it comes to cleaning the toilet, toilet floors, toilet pots, toilet seats and lids, toilet sinks and toilet soap dispensers, very important, should be cleaned with either a 1% sodium hypochlorite or a phenolic detergent 3 to 4 times a day. And of course, again, for the taps and metallic surfaces in the toilet, such as the shelves sometimes are metallic, sometimes the toilet paper containers are metallic, the taps are metallic. For that, you use 60 to 70% alcohol. There's also guidance, which we have in the same document, on how to handle patient examination tables. And this is to answer one of the questions also. Ideally, use disposable linen. That means the paper sheets. And if you're not using those, then you must change after each. And whatever linen you've used, including patient towels, should be washed with standard detergent in a washing machine, because hand washing is not really going to be enough. Routine machine washing with the regular detergent is adequate for all the non-disposable sheets and covers. But very often, the edge of the mattress and the edge of the examining table can get virus sitting on it, transfer from a patient's hands, or because the patient was speaking too loudly when they were sitting down, and so on. So in this situation, use the entire amount of alcohol that you have to clean the mattress and the table edges. If you have lots of alcohol, that's ideal. But if your sanitizer is in short supply, then a 1% sodium hypochlorite solution, and you scrub it on, leave it on to dry right there. Remove any excessive bubbles if you need to, but you can use that as well. But ideally, 70% alcohol solution. Now, do remember that this dear virus of ours can persist for 96 hours on and on and on and on. And therefore, we need to be very, very careful. And that is something that you and me have to be attending to. And that is that our dear machines, which we touch so often, especially areas on the patient side, handles, and so on, need to be sanitized. And here I'm going to take the help of Dr. T.L. Praveen to tell us about equipment sanitation.
Right. Thank you, Ashok. I think it has been a very elaborate way of putting across various precautionary measures. Now, as an ultrasound center, the most important things is your equipment, your patient's couch, and your patient's preparation. So quite often what happens is, when we take the F form, what we have been following is a very simple procedure. In the sense, when the patient is asked to fill the F form, we ask the patient to fill with a pen, and that pen is not reused. We keep it in 5 boxes. If suppose today I have used one box, 1 pens, tomorrow I'm not going to use that one, and 5th day I'm going to use the same thing. So that way we are giving some more time. We sanitize the pen and then keep it there and then reuse it after 5 days. So that's what we have been proceeding following. Now, second important thing is, as far as the equipment is concerned, particularly the areas where you are going, that's what is called as the high touch areas. As far as the person who is doing, that is the doctor who is operating it, these are the areas which have to be very much clearly sanitized, in the sense using most often by using what is called a 70% alcohol. so that the desktop, that is particularly the knobs on the machine, can be easily cleaned and protected. Now, coming to the transducers. Transducers are one of the trickiest things because we are always worried about the transducer face because it can get corroded or it can get damaged by using certain chemicals. So that's the reason why we are worried. Now, at our place, we have started using, we all know when we do these invasive procedures, we try to use a glove over a transducer. Particularly when you have what do you call it as a convex probe. In that situation, we use the regular hand glove, the sterile hand glove, put the gel onto it, strip it over the transducer, and once the examination is over, remove it and throw it off so that you are very sure that you are not going to have any contamination. At the same time, we are very sure that you are not going to damage the probe surface. Then coming to the transvaginal or transrectal applications, we know that we use condoms, but nowadays we have started using double condoms so that we are much more sure about it. Now, another area is quite often we have a habit of not cleaning the entire transducer very clearly because the source of infection or source of contamination is basically when you leave a lot of gel over the transducers. So that has to be very clearly cleaned. Now, when we clean that one, because even if you remove the glove also, there is some amount of gel which is already stuck to the transducer. So that can be cleared by using certain swipes. There are swipes which are very, very effective and they are all disposable. So you can use that, clean it and then throw it off. And then coming to the cables. Nowadays, after this situation has started, we have started using what is called as the laparoscopic covers. Most of us, we know that during laparoscopy, we use certain thin protective layer cover over the tubing as well as the cables. So that sort of a cover is now being used for the transducer cables so that we are much more sure that we are not going to involve the cables and not going to have them as source of infection. Then coming to the patient's couch. The patient's couch is again an important thing. If you have a Rexine-based couch, that Rexine-based couch has to be wiped by the disinfectant before the patient comes in. Now we started using what are called as the disposable paper. This disposable paper, most of us might have seen while we go for these marriages where they put it on a table and put the white paper and then cut that off. The same paper can be used on the couch so that you first wipe the couch with your with a sanitizer or a disinfectant and then put this one over the paper over it so that we are much more sure. And then covering the patient is not really required because quite often the patient does herself and then there is an attender with you so that you will be much more comfortable. Then another important thing is while putting the data onto the equipment, it is essential that it is better that one person does it. It is always advisable that you yourself do it so that you know where you commonly touch the buttons and then you can disinfect that area. So these are the things which are extremely important and they are the things which have to be taken care of, and this is a day-to-day problem which we are going to face as we start using or giving ultrasound services to the patients. Thank you, Ashok.
Thank you. In fact, on my slide here, as of last night, all these brands were available as wipes or as liquids, and they are available on several sites. And because this comes under essential services, you can have them. We've also found out from several grocery stores which keep other household stuff as well that these are available and you can order them in advance, place an order in advance. That's what people are looking for and it should work out quite right. So we have a large number of brand names available. These are not any that we recommend specifically, but the fact that these are the ones that are currently available. Now, the one question that I want to now cover up together is this business of the COVID designated centers. And maybe Dr. Aparna, you can answer this and a few related questions. And one is the precautions in a COVID designated center, whether we need to aerosolize the corridors with hypochlorite, anything special different from HIV for these particular procedures in the COVID designated center, and also for a general center, what do I do for an amniocentesis or a CVS? You'll have to unmute yourself. I think you haven't unmuted yourself.
Yes. So even for a COVID designated center, so like for the areas that are doing scans, although we are not doing scans per se for the COVID positive patients very extensively, but even areas, because we have done cesareans for COVID positive patients, so even in those areas, the disinfection remains much the same. The surfaces are cleaned with hypochlorite, and the aerosolization is not done as much. The surfaces are cleaned with hypochlorite and the area is fumigated, and it is left for some time. So I think that is the basic precaution which is taken. So I think that is as much as it is done. And I think there are a lot of queries which I thought we should be answering. The first one was about invasive procedures. So regarding the invasive procedures, I must say that these are the things that we cannot forever avoid. I think we have all been trying to postpone these procedures for the lifting of the lockdown as much as possible. But if you are screening, like we are doing cesarean sections, so these procedures are actually much lesser surgeries than cesarean sections. So if you are screening your patients properly and you think that they are screen negative, and so we need to go ahead with these procedures because these are time-bound procedures. So if your center is equipped enough and you think that you are safe and adequately equipped to do these procedures, we can go ahead to do these procedures. So we have a screening system in place and we are doing procedures in a very, very safe manner, taking all precautions. So that is number one. And there was another question that if you are from a quarantine, if your patient is from a quarantine society, then you send that patient to a COVID designated place. So you please don't do it if your center is not a COVID designated center. Then the other question is a very interesting question, that are we doing a COVID serology in all patients? Now this question actually came up in the routine COVID task force meeting that we have in AIIMS every day. That should we be doing serology for all asymptomatic patients before doing a routine surgery? Now, if we do routine COVID serology for all patients, asymptomatic patients, then serology, even if negative, the patient might be positive in 30% of the cases. So false negative is 30% right now. So it's a very difficult question to answer at this point in time, given the sensitivity and specificity of the tests. So right now, the best tool that we have is screening of the patient. So if the patient is asymptomatic, so we will have to decide whether we have to do the test, how important it is for us to do the test. And if we have to do the test, take all precautions and do it, right? Or if you can postpone it for a few weeks, just postpone it. Like there was one question on amniocentesis at 16 or 17 weeks. So maybe just wait till 19 weeks, at least you have a QF report within 1 week, so that you are, even before 20 weeks, you have a report. So those are the questions that you need to individualize at the present time. Also, there was one question about monitoring in twin gestation. So you need to decide those questions, like you cannot avoid doing an ultrasound for fetal anemia. You cannot avoid doing ultrasound for severe growth restriction. Similarly for twin gestation, if it's a monochorionic twin gestation, and the patient is having growth discordance, you will have to do an ultrasound. If, however, it's a dichorionic twin pregnancy, you do an ultrasound in 1 month. So those are the questions I think I saw which were relevant to me, and I thought we could answer those questions.
Yes, while you've answered those, can you also clear that question on the lower segment evaluation?
Sorry,
there was a question which said that if somebody is 36 weeks and she needs a scar thickness assessment, should we go ahead and do that? If the patient is 36 weeks pregnant and she needs a scar thickness evaluation, should we do it?
Scar thickness evaluation I would not do in normal times, so I will not do it in COVID.
That's a different matter. But if you were doing it, you could of course do it in case the patient really felt really good about doing it. Thank you for that, for answering a lot of quick questions. I'd like to wind up with a few things that still need consideration. One is that we must accelerate giving our reports. We used to have the advantage of couriers. We don't have that anymore. We try, some patients insist on a hard copy. We try and accelerate this, but I personally make them sit and wait in the car. They can't go to a restaurant anymore. But we tell them that, look, it's much nicer if you can access this from our website or by email. We can, of course, share this by newer platforms that can actually send these across to the doctors who can see this information. We can't share images in a report with our patients directly because that's not yet received final PCPA clearance. It will in the near future. And of course, the other important thing is that we must stock up our protective devices. We truly must be practical. This is a nation where we like to hoard. When it's available, we like to buy 3 months of supply. We like to buy 4 nice warm covers, blankets in June so that we can use them in December. But let's not do things that are not necessary, but protective devices, we really must do that. And then there's staff consideration, which is very important, that we do have members. For instance, I have members who've been with me for 35 years in my clinic. And obviously, they're on the wrong side of 60. So am I. But the fact remains that chronologically older individuals should be then put to work in areas where they don't have exposure. And that is very important, such as in patient preparation, in report preparation. And the staff should be rostered to work for shorter working hours. And this was an excellent input from Dr. TL and Praveen, that we can work in rotation. Not everybody works every day. And then, I learned this also from the triage input from the military, that look, doctors have to be there and staff have to be there to look after patients. So if we work on alternate days and divide our staff at least, if one set gets exposed, we'll actually have the rest of the set over there for assessing this. So that is how we need to do that. Also, one staff member per shift should be given the responsibility of ensuring staff and patient compliance. And we don't allow staff to listen to any nonsense. We tell them, look, please tell the patient, if you don't put on the mask, we will not see you and please leave the clinic. We also tell them that, look, there's just too many attendants. We allow 0 in the room or maybe 1 in the room, depending on what is your personal policy, and everybody else should be out of the campus. We also say that the staff must be told again and again how to wash their hands. Every instruction we like to repeat every 1 or 2 days because staff likes to forget very easily and they are anyway working under stress. And we insist that phone scheduling should be detailed, and we spend almost as much time these days on an ultrasound scan as we're doing on the initial thing. Someone asked us to repeat what TOCC stands for. It's because they joined us late. It's travel, occupation, contact, and community. And therefore, it's something that we need to assess very carefully. Then, of course, we must fill out every section on that form. This is going to be a police document very soon. And therefore, we really have to be careful about that. And, of course, social distancing. And in case you do need to have a very advanced PPE, what is it? Somebody, again, wants to know about the difference between wearing a standard surgical gown and the high-flown device. Obviously, a standard surgical gown is good enough, but in fact, even fresh clothes are good enough. So to conclude the formal part, and I promise you we're not running away, we knew this was going to extend. We knew we'd have millions of questions, and we've received a huge, overwhelming response. We've answered about half of them so far, but we'll answer the other half. But let me put in, for the sake of completion, some concluding comments that we have to prioritize, and we have to optimize, and we have to use our innovation to do so. These are minimum guidelines. We have to build on these. Also, we must have an emphasis on making sure that we don't infect our patients and our patient does not infect us, and we must protect ourselves legally and make sure that the declaration is clearly filled, including current address and permanent address. The number of visits should be reduced to a minimum, and we've discussed that for twins as well. And of course, wise to consider colleagues, staff, and patients as asymptomatic carriers and follow PPE measures. PPE, personal protective equipment, which ranges from medical or surgical masks, goggles, and goes on to fancy stuff, which we have already discussed at length. Do remember that these are guidelines as of today. Science evolves, and we do understand that concepts might change. Tomorrow we do understand that we will all be sensible if we wear gloves, if we wear masks when we go out, and the mask should be properly worn and cover the nose and the mouth. And that will prevent somebody coughing on somebody else and somebody coughing a surface that I might go and touch a little later. And so if masks have evolved, so will other things, and we will bring you that on our website, which is www.societyoffetalmedicine.org. I'm not going to thank my colleagues as yet because I have a sheaf of questions here which we're going to be answering. But I'm going to keep this in the background because it's going to tell me what I can use and which slide we can shift back to. And the first question which I'll answer right away, which has already been answered, and that is probe cleaning, preferably by Sidex or 70% ethyl alcohol. Actually, we can use a combination which is available, and they're both equally good, and they're approved by most vendors. Most vendors in the time of COVID-19 have given their own specifications as well. So you can call the company you bought the scanner from and they will let you know. But the list is pretty much the list that we have given in the guidelines and that we showed in our PPT, that a combination is equally good. There was a question on how do we dilute the Sidex. The fact remains that you can dilute the Sidex exactly as is given on the cover of the Sidex bottle. It means that the solution is there and there's a little packet which contains the Sidex powder, and you empty it out and you put the date on that, and it is valid for 3 weeks. And of course, in this day and age, a bottle of Sidex, which is about this big, gets used up within 3 days. But what else can we do? There's also this question on, can surgical gloves place heavy-duty gloves for cleaning staff? Surgical gloves with latex? Certainly no. They're prone to wear and tear. Frequently changed polyurethane gloves? Yes, but ideally heavy-duty gloves to protect them. We've discussed the aerosol corridor, which we know is safe as long as nobody is actually there, but we don't let patients pass through an aerosol corridor. That is not allowed. And then we come to our next set of questions. And one of these is on what material to be used for sanitation of probes. We've discussed that in detail. And also a question on privacy, on should somebody put up a list of people who are infected and should we use those? I'd like to answer this myself. We cannot do that. Medical privacy needs to be respected even in this time. And we have to depend on whether our patients are telling us the truth or not. Let's protect ourselves. And yes, we can have areas where this is on. And there was a question on what are the lists from Pune and Nasik. Every Ministry of Health and Family Welfare at the level of the state is giving a list, and they have a list which is continuously running on areas that have been identified as where super spreaders live or which are high density areas for COVID-19. And these are updated every single day, and you can go back to that. There was a question on the impact of government Arogya Setu app, and can we tell the patient to download this and fill it? It's so much better to get your own qualified staff to actually do this. And now questions for my panel. When we say we should prioritize second trimester over first trimester, are we saying that we do a second trimester anomaly scan rather than the first? Or do we mean that when we have an overload of patients and I have to reject some patients, should I do an anomaly scan rather than an early morphology 11 to 13 week 6 day scan? Dr. Aparna, please.
No, this is to counsel your patient that in case you have missed the first trimester scan, so it is all right, you can get your second trimester scan. That is to say that. So it's not that you voluntarily miss it. So it is to counsel your patients that just in case you have missed the first trimester scan or you're not able to come for your first trimester scan because of the lockdown, you're in an area, you're in a hot spot that you're not able to move out, then you still have your 18-week scan to go for it. Like we have to be rational about it and not die for a first trimester scan. That's the point.
And the ISWAC statement on giving a second trimester anomaly scan preference over a first one refer to patient overload where healthcare is free. So if I'm loaded with having to do 10 scans a day and have a request for 9 anomalies scan at the 18 to 20 week interval, I will, at the 18 to 20 week window, I will do those first compared to a first trimester evaluation. Then we have questions on sanitization of the machine. We've covered that. Standard gowns versus non-standard gowns, the full value of TOCC and so on, we've answered those. And should patient put on mask compulsorily? We've emphasized this. Every patient, every attendant, everybody in the building must have the so-called medical or surgical mask. We have a whole lot of new questions that have come in, and those were on whether these are only until the lockdown or till the pandemic is officially declared over. Dr. T.L. Praveen.
I think we need to, till the pandemic is really declared over, because, there is no guarantee that once the lockdown is taken off, that we are completely free. It's always better to be careful, and it's always better to follow. Anyway, you're now getting habituated to using all these things together, so as well continue till we are really safe.
Yes. And so therefore these will just carry on for a long time, and we will update you maybe in November or December that we can be playing safe again. After all, when international travel is resumed, when lockdowns go away, it does not mean that the disease does not exist anymore, and therefore we have to be careful. In fact, we have to be more careful when travel starts again, and people start traveling more and more, and make sure that people are telling us the truth when they actually go about it. Now, then there is this question that people have been asking on sending samples to other cities to genetic labs. And people feel it's not happening. But I think the panel would agree with me that all the labs are doing an excellent courier service under the services maintenance, and that cargo air is open. So even if they have to send it to another city, it is open. And cargo is open, human travel is not open. And therefore these invasive material, the amniotic fluid, as well as CVS, etc., blood samples, and samples the maternal contamination of our invasive samples are all working.
Correct.
There is one question which is to a specific brand, whether Sterilium and Bacterub can be used to clean probes. Of course, both of them can be used. Just reconfirm with the vendor of your machine whether it is safe, and they usually are able to do so. So that is one question. Dr. Taylor Praveen, is it possible to use ultrasound gloved left hand on machine and right hand on transducer and no interchanging hand? That means we use only a left hand glove and we don't use a right hand glove. Dr. Praveen, what do you think?
I think that is cutting corners. I feel it is better to use. I don't really. I'm not really comfortable using only one hand with the glove and the other hand. I don't really get any benefit out of it.
Yes, Dr. Krishna, would you agree that we should not cut corners? You'll have to unmute yourself.
Yes, sir. Yes, sir. Definitely. We should not cut the corners at this situation.
Yes. And now one very interesting question, that a news item said that PCP&DT Act is suspended till 30th June. And in fact, we had the NGOs and wonderful people like the great leaders of this country saying, this is terrible, without reading the fine print. For everything, you must read the fine print. All that they said was, we don't even have the time to receive your papers. We don't have the time to look at them. Do exactly what you're doing. You may not need to upload on a daily or a monthly basis if that is what is being followed in your district, but you will have to submit all of this after 30th June. Please make sure that all such inquiries can be sent to us at Secretariat, Society of Fetal Medicine, or to any one of our executive committee, and everybody's list will be up on the website by day after tomorrow. We will answer this question for you again and again. We have to stop depending on half-baked media reports. We have to stop depending on the University of WhatsApp. And to a great extent, we have to stop attending to the so-called pseudo-blogs, which are non-scientific and written by people who are good at literature and fanning all kinds of emotions, and we have to be careful about those. Now, there was a question on protection for front desk staff, and I think we've done that again. And then someone suggested to put a disclaimer at the end of the report that adequate precautions were taken for the safety of patients at the present pandemic of COVID-19. So this is something we did not consider, but I'm quite happy this question came up. Who on my panel? Let's start with Krishna. Should we put a disclaimer at the end of the report that adequate precautions were taken for the safety of patients at the present pandemic of COVID-19?
Sir, we are taking the consent form, so that is solving this issue. But still, we can put this disclaimer. It is not a bad idea.
It's you have to look at the psychology of your own patients. There's some areas, parts of our world, parts of Delhi city as well, where the psychology is nasty, and I think this is a brilliant idea that they can give a printout of our consent form, the whole thing. Why only just an abbreviation? Print it out as part of the report and give it to them. Dr. TLN, what would you think?
Yeah, I think as we have already have a very detailed consent form.
Yeah.
Putting this again, maybe your idea of keeping the consent form to the report form it's equally good.
Yes, and one question, Dr. Parna. In your kind of a setup where there's so much of pressure of people needing ultrasound scans, a general hospital running COVID and general at the same time, how would you manage the consent form being added onto a report? I mean, you barely have time even to write the PNDT aspects for the report. Where are we going to manage this extra bit?
Yes, sir. So currently, what we are actually doing is that we have made a screening place. So in these times, I think this is extremely important. So what we have done is that we have made a screening area outside our labor ward, the main entry of the obstetric ward, so that no woman who's entering the area enters without the screening and a consent form. So despite being a busy area in these times, there is actually no option for us to incorporate this consent and the screening form being in the patient file. And I think this needs to be incorporated in every setup because there is no two ways about it.
Yeah, so we have put it on the report, yeah, but it has to be part of our record.
Yes, yeah. So we have taken this part from the SFM guidelines as well, and we have added a few more areas to it. And we have put this in the main file of the patient as well, that this has to be done. And no woman enters our labor ward without the screening being done, without the consent being taken, despite the rush, despite everything. So this has to be a reflex for us that this needs to be done.
Yeah. Now, there is a very important question on what will be the fate of our clinic if either the patient or the staff or I get COVID during the lockdown or after the lockdown. Will it be sealed and for how much time? Of course, it will not be sealed, but could my panel, Dr. Parna, can you start this off? What is the method of quarantine in case we are working like this? Who all should stop working and who all should go home?
So I think, sir, I will just start this off by a very interesting incident that happened with me yesterday. So I was working and, one of my patients had an obstetric emergency, and it turned out that, she had a bit of dyspnea day before yesterday, and we had to send her nasal swabs just before the procedure. And it turned out that till the report was negative, which the report took some 8 hours to come, all of us thought we were suspects. So what really happens is that during this time, when we think that we are suspects, so what happens? And if we are actually exposed to a COVID patient, what happens? So we have to understand that if we are suspects, we are not really locked down. And even if we are exposed to a COVID patient, we are quarantined, right? So we are not locked down or sealed, we are quarantined. So when we are quarantined for 14 days. So if you are exposed to a COVID positive patient, you and your clinic staff or whoever is exposed is quarantined, during which time you are under observation for development of any symptoms. Ideally, according to the current guidelines, you are tested on day 5 and day 14. So that is the protocol which is followed. So, and you are observed, you are under self-monitoring for symptoms, and you are tested on day 5 and day 14. And if you are negative, all is well and good, and you are back to work, right? So it is fine. So
for those 14 days, you have to stay away from work, and all the staff has to stay away from work.
Yes. So for those 14 days, stay at home and stay in isolation. Your staff, everybody who has been exposed has to stay at home and stay away from work. Be in isolation. Do not be in contact with anybody else. Even at home, stay in an isolated room as much as possible, and use one single room and washroom, and be in isolation. So on day 5, you have to get tested, and day 14 again you get tested, and if that is all right, you can be back to work.
And then there are 2 questions related to economics, and one of these is, Dr. Kiran Praveen, can we charge extra to cover the additional costs of all this sanitization, reducing the number of cases, etc., etc.?
I think on humanitarian grounds, I think everyone is doing their bit in this tough time. I think this is a little contribution that we can extend ourselves. I think it should not be that we should charge extra for the precautions that we are taking, not only for the patient, but also for ourselves and for our staff. So this includes the safety of our staff and ourselves. So I personally feel that we should not charge extra in these times. This is the time when we need to be more magnanimous.
Yes, thank you for that input, and that's a personal opinion, of course. There's a question on what is the basic protection for front desk staff. We've discussed that already, and you can access these on the guidelines. And guidelines of fumigation of stand-alone clinics for TOCC category. Again, we've answered this at length, and we don't need to go into this again. And if there are any further questions, please feel free to be in touch with us. Then we have this on whether we can use 60 to 70% alcohol to spray on the sonography bed. We use 60 to 70% alcohol, which is more expensive than 1% hypochlorite, but we don't spray it because that spreads the virus. What we can do is that we just clean it with a wipe all over, not just the edges, but the entire mattress and the metallic surface, and then that should be fine. Then we have a question of if patients insist on doing an anomaly scan with a female attendee. Well, we have no choice on that, and I'm just going to get my power link connected to my laptop. I think I was wrong with the power, and if I can just yell out to my good friend Vishal, and bear with me for a second, because otherwise I'm going to run out of battery, and I did not anticipate that the switch might be off. We're so scared of switches these days, but I will just be back in a second. Vishal? I need power input. Yes. I need input battery input for my laptop. It's lying here, the charger and the. So the question that we wanted to answer was for the female attendee, and Dr. Krishna Gopal, can we do without a female attendant?
No. If the female staffs are there, if your female staffs are there inside the room, we can do it.
Exactly. We don't have to have a female attendant from the patient side. We have our own staff, and truly speaking, that would be absolutely fine. Now, when the patient comes from a red zone area, so to say, is it good enough to categorize them into TOCCB category? Dr. Tiran Praveen, is that the right way to do it?
What do you mean by red zone area?
I presume that this question refers to the community area, which has been identified as a hotspot. Yes.
Yeah, definitely. If they are coming from a hotspot area, I think we need to consider them as a TOCC category B.
Yes. There is a question on the side about infertility treatments and IVF cycles. I think we have guidelines from the European Society which says that we should not do actual cycles, but you can do remote consultation. And the American Society of Reproductive Medicine last night also issued a guideline that you could do remote consultation, but not to start procedures as yet. Now, we have some more questions, and I'm going to not refuse any of these questions. And that is, can we put a statement at the end of the report that this could be a suboptimal scan due to the limited time being spent on the scan? And of course, the second question that would arise is, how should we logically shorten scan times? Should we call a patient back? Should we make them sit and wait? Let's try and get to the bottom of this. Each one of my panelists, please. Dr. TL and Praveen, first you.
Yeah. Basically, this is the problem which I have felt was very important, because quite often in the given time, it may not be sufficient, but then you can't put a disclaimer saying that because of the limitation of time. I don't think that stands good. So I think it is your responsibility to see that something is achieved. See, quite often in our day-to-day practice, we definitely do sometime an extended examination. In that situation, we ask the patient to wait for some time and then again take them back. In this situation, you can do the same, but only thing is, the problem is that if you keep more and more number of patients being waiting there, then the waiting room becomes a little more crowded. So that's the reason why we can ask them to come back for a reappointment, but then again it's not very comfortable to the patient. So I would prefer to send it to a colleague of mine, where he can also have a look at it, and it will be in or if you have multiple partners who are working with you, definitely you can ask another partner to take care of it. So that way, I think it is better to do it rather than putting a disclaimer saying that because of the limitation of time, this is not it's a suboptimal examination. No, we don't agree with that. I don't agree with that.
But would we be very wrong to just call them back and say, look, you run out of time? Or can I just tell them, look, can you just wander around and come back later, perhaps?
Yes.
Or maybe even the next day. Dr. Krishna, how would you handle this situation? Your patients come from very, very, very far away.
Yes, sir. Actually, certain situations are there, like the patient who is living nearby, and I have finished 90% of the scan, and just the spine evaluation is remaining. So what I do, actually, I send them to their home, and whenever my coordinator feels like, and there is a tentative time we give them, and then we call them again. There are patients who come from far off, very far off. So we start it early and try to finish as much possible. Then we ask them to go to the either vehicle or to the adjacent room. So we have just empty one of our rooms for this kind of distant patient, but it is a good idea that we should not compromise upon the study. And I second Dr. Parveen sir's opinion that we should not write any disclaimer that it is a suboptimal scan due to the limited time. We have to give the time what is prudent for these patients, and we must allow them. We can in fact short the exposures by doing it multiple times, but we have to finish and give as much time as this scan needs.
Yes, but if all said and done, I didn't see anything, I would just say, look, an attempt was made, the patient was called in multiple times, and the face and heart were not adequately visualized over the course of our working hours, and the patient is advised to reschedule. I mean, after all, we have to face facts sometimes that, look, we're working a quarter day or a half day. We don't have I work in a limited number of consultants in the practice, etc. Just me and a colleague. So I would just tell the truth in the report and mention it in the body of the report and the end of the report. Dr. Aparna, what would be your opinion on this? Because you're overloaded at all times.
Yes, sir. So I would agree with what you have said, and I think what sir has said. And but the only thing that I would like to add is that in these times of pandemic, I would really avoid patient traveling back and forth. That is my own view.
So we have to draw a balance.
Whenever a patient comes to us, we just kind of would not like that patient to go and come. And for us, the additional advantage being that we do have an admission facility, not for ultrasound per se, but for any other procedure that we do. For us, the most important thing in these times is do not let the patient travel, because for them, traveling is the worst thing right now. And so just make sure that traveling is kept to a minimum.
Wonderful. And there's one question on our hospital has few beds reserved for COVID patients, but a single ultrasound room and radiologists. And what PPE should be used?
So, sir, I think this is a very tricky situation, and they should have a stock of full PPE available with them. Because I think there can be a mix of patients here and there. So I think they should be very careful. This ultrasound room should have a proper triage outside their ultrasound room. And whatever patients they are coming to for scanning, they should have a proper history indicated and also a symptom-based screening outside. And depending on that, they should have facility for donning on proper PPE and, facility should be available.
So technically then this becomes a B or a C category PPE
the
situation.
Possibility of a B and
There's
C.
no question of an A situation, and we need to protect ourselves.
They have a mix of patients. Yeah, they could have a mix of patients.
Yes. We have a question on filled up forms. Do we have to keep it or do we give it to the patient? Dr. Krishna Gopal.
Sir, we can give one print of it to the patient as well.
Yes. And ideally, of course, there is this paper saving, there is this business about the environment, etc. But there is no doubt that we have to keep one copy for ourselves. And we give a copy to the patient for the simple reason that for the frivolous amount of accusations thrown at the medical profession, evidence of this sort will remind them that, look, don't play around with these things. These are serious matters, and let's be mature when we truly handle this. I think that would be the best way to do this. I have just looking through to make sure we didn't miss any category of questions, etc., etc. And we seem to be quite all right. But I believe we have some more questions and we have a few minutes to answer those as well. I hope we're not all terribly hungry because I know that everybody here is hungry for knowledge and we are doing our best to meet that. And we did anticipate that we would take much longer, that we'd have to move at a slower pace, that we would have a barrage of questions, and therefore what can we do? So this is a very interesting question on, can we use transparent sheets as barrier hanging between patient table and ourselves? And if I may answer this question, this is a very interesting image on WhatsApp from a Dutch department where there's this huge plastic sheet hanging and a hole for the arm. And it's impossible to maneuver your arm with that. So it doesn't work. I think if you're really, really scared, then a complete facial shield would do as well. There are also this question that are instances where hospitals are sealed. Yes, a hospital is sealed when it needs to be put into quarantine because a lot of the area in the hospital has been done. Unfortunately, with we have two pandemics that are going on at the same time, as you will agree with me. One pandemic is of the coronavirus and the other pandemic is of human stupidity. And therefore, patients are being ridiculous and risking the life of a whole nation. We have no choice but to take steps. But in terms of hospitals being sealed, it is within the authorities' sort of perspective to do that. There is no doubt that they will not seal. But we know that we live in India and these things can happen. It's nice to be in touch with the right people so that unnecessarily this doesn't have anything that we would be worried about. So we've actually covered all the rest of the questions completely. One nice final remark from each one of my panelists on what they think is the single most important thing. Dr. Krishna Gopal, please.
Most important is to be safe for yourself and your staff, and try to be honest with your patient as well. Try to educate your staff, yourself, and to educate your patients, attendants, as well as your referrals.
Thank you. That's very nice. Dr. Aparna, how about you?
I would just like to say, sir, pandemic or no pandemic, obstetrics will happen, obstetric ultrasounds will happen. So we have to be prepared and we have to be safe and keep our patients safe. So be knowledgeable and do the best for yourself and your patient.
And Dr. T.L. Praveen, as the president of the Society of Fetal Medicine, which we understand today has become an international contender for being something that is with the doctors, with the patients, what is the message for everyone on this webinar?
Well, the main aim of having this webinar was to educate ourselves, to know all the adequate precautions that we need to take, about following them. And the main aim is that to keep ourselves, our staff, our patient and society safe. That is the most important thing, and that is the goal which we were trying to achieve by having these guidelines framed, having these webinars conducted, so that most of the colleagues who have been practicing obstetrics and obstetric ultrasound are going to be benefited by. There are umpteen number of doubts which you come across whenever you have started doing your work. You know that there is certain ambiguity in the whole situation. So as far as possible, by educating ourselves through these guidelines as well as webinars, we are going to keep ourselves safe and our staff as well as the patient and the society.
Thank you for that. I'd like to end with thanks to our expert committee who put these guidelines together, and to Lifestyle Diagnostics once again for partnering with us for the spread of education and for the spread of knowledge and awareness. And our good friends, our great telecommunication company, our webinar partner, Blue Jeans, and Reconnect, which has really made sure that this went off without a glitch. Thank you, each one of you, and to the delegates for taking time off on a Sunday, on Easter, at a time when we have relatives we're worried about, at a time when life is very low on cash and money, and a time when life should be high on ideals, to sit with us for 2 hours to go through this, because it means the world for that patient who's going to be having a baby. And of course, it means safety for us. Thank you very much, and bye-bye.
Bye.
Bye-bye, sir. Thank you so much, sir.
Thank you.
Recording has stopped. The moderator has ended your session. Goodbye.